So we've talked a lot about the manifestations and pathophysiology behind chronic kidney disease. And while we've been doing that, we've talked a lot about the care. So I'm going to run through these slides really quickly and just kind of highlight things that we maybe haven't talked about yet. And also just kind of remind you, okay, if you don't, for example, with this slide, hyperkalemia, I've talked a lot about how we treat hyperkalemia. So if you've missed it, you can go back and look at that video, okay? So when we have acute kidney injury, which is the first type we talked about, our goal is to restore the kidney's function, right? We want to fix it. With chronic kidney disease, the goal is just to preserve what is already working, the renal function that's already there, and to delay progression of the disease. We also will want to treat any of the manifestations, anything, for example, hyperkalemia, and prevent any further complications. Okay, so we've talked about hyperkalemia, we've talked about how to treat it, we've talked about the side effects, what we want to watch out for. If you're still struggling on that, go back and take a look at the video on electrolytes, I believe, but I'm sure you'll be able to find it. Here is that generic name for K-oxalate. I couldn't find it on the other slide or didn't know what it was. Sodium polystyrene sulfonate. You can imagine that's a pretty big mouthful, so we all just say K-oxalate. Okay, so hypertension. So this is going to be different depending on whether the person is diabetic or not. If a non-diabetic person has a blood pressure around, so we're worried about, you know what, let's just let it, we're worried about all of the effects of high blood pressure. And you've probably, in every single unit you've taken, you've learned about some effect of high blood pressure. And we know that kidney injury and kidney failure causes a water retention, which increases the amount of blood in your system, which then causes hypertension. So especially if you're already diabetic, if you already, let's say, have a history of stroke or a history of MI or what have you, that's all this is saying basically. And then these lifestyle modifications are just that much more important for you. So we're going to do things like exercise, weight reduction, get no alcohol, stress management, low sodium, low fluid diet, and you're going to do antihypertensives. I'm not sure why they have ACE inhibitors here, because ACE inhibitors do have an effect on potassium, but you might want to double check and just look that up. Yeah. And I will move on to, we talked about why you would have a bone disorder, right? Because of the relationship between vitamin D and calcium and so on. So we're going to limit the intake of phosphorus because we're going to have hyperphosphatemia. We don't want that. A phosphate binder will bind the phosphate to the calcium, right? And then when the calcium is excreted, the phosphorus will come with it. Supplemental vitamin D, we've talked about why that is. Magnesium, again, we just want to be careful with using anything that will increase that excretion of calcium in our body, right? So here we have to watch, because we're taking calcium supplementation, then you have to watch for hypercalcemia, right? And you can go back to the hypercalcemia video, check that out. Hypocalcemia, again, vitamin D, bone scans, bone biopsy, all of that stuff. This is when CKD has gotten, it has been attacking your bones for so long that now you have a basically degenerative bone disease, right? And we want to keep an eye on your parathyroid hormone as well. The most important things I'm trying to just highlight the really important things on the slides, and so I'm not going to hit every point. Anemia, we've talked about. What do we do for anemia? We've talked about Y, which is right here. We want our target hemoglobin around here. This is, for now, just something you have to memorize. At a certain point, again, it'll just be second nature, that when you see hemoglobin of 55, you'll know it's low. We don't want to use, so normally if somebody is anemic, they have low red blood cells, right? Or blood volume, could be either one, right? We normally would give a blood transfusion. In kidney patients, we don't, well, we're cautious with that as well, more so, because the transfusion, right? The reason that the kidney releases erythropoietin is because it senses a low blood volume, and then so then the erythropoietin will stimulate RBC production, right? So if you end up giving blood transfusion and you have a decent blood volume, it's not going to kick the kidneys into actually doing that, right? So we just need to be mindful of that. It's not something that you would never do. It's just something you need to think about. Your dyslipidemia, you're going to treat with statin drugs. Complications of drug therapy, I'm not sure what they're trying to say here. Any drugs, basically any drugs that you're giving, you want to remember, is it excreted in the kidney? How much of it is excreted in the kidney? Could we do something else instead, and so on. And then again, we're talking about NSAIDs here, which are nephrotoxic. Nutritional therapy. This protein thing really gets you. Let's see what they say here. So if you're not on dialysis, we're going to restrict protein. Again, it's like I said, we don't want to eliminate protein. We just want to have a low protein diet. And then when they are on dialysis, you want to have it a little bit higher. Okay. Just look through this. I actually know that I did have a question about protein relating to dialysis on one of my tests. I don't remember when or what test. And I had to know that I needed to restrict protein to a little bit, or have a low protein diet when the patient is not on dialysis. Sodium and fluid restriction we've talked about. Potassium we've talked about. Here's a lovely list of things that are high in potassium. If you're like me, you hate all the questions on the exams that ask about food, because I don't typically know what's in which foods, but there's a list for you and you can just memorize it. The only one I know is bananas. Hypocalcemia we've talked about. Again, I'm not going to go through that again. Severe hypo, but we've talked about this again. So if for some reason, because we're playing with the phosphate and the calcium levels, like, yes, you're more likely to have hypocalcemia, hyperphosphatemia, but you're playing back and forth. And with the calcitonin, it can shoot back and forth a little bit, right? So you can give sodium phosphate or potassium phosphate, watching for symptoms. And again, if you have hyperphosphatemia, we just talked about phosphate binding medications, and then correcting the hypocalcemia, which will correct the hyperphosphatemia, right? Okay, we haven't really talked a lot about magnesium, because I know it's another one of those ones that I don't think it's ever come up on an exam related to kidney disease, but you can use IV magnesium. We do give that quite a lot. You need to monitor vital signs. It does have an effect on blood pressure. So when I give magnesium in the ER, again, it's one of those things where I check blood pressure first. If the patient already has low blood pressure, it's something that I would definitely, if they need the magnesium, I would definitely give it slowly. And there on the next line, it says that rapid administration can lead to hypotension. Okay. That's just something like you learn as you're working. Magnesemia. You want to eat have a low magnesium diet. There again is a nice little list of foods there. I'll never remember those as long as I live. This is why I'm not a dietitian. If renal function is adequate, you can increase fluids and diuretics to promote urinary excretion. I'm going to be 100% honest with you guys. Magnesium is not a strong suit for me. And part of the reason for that is because I don't think it's ever come up on a test for me. I know things about when I'm giving it at work, because when I have given it, there are things that I have to think about, and I've been taught that. But in terms of a test, it's a little bit of a weak spot for me. So you might want to go back and just read through. Again, I don't know that it will even be worth it for you. So you make that decision. Now watch, there'll be 10 questions on magnesium. And yeah, we've talked about all of these things. There's nothing here that I don't think that we've talked about. Encourage discussion. Those are those nursey questions. Okay, so it says explain rationale for the prescribed drugs and common adverse effects. And this is actually a really, really huge thing. I find a lot of nurses don't do that is really helpful, first in building a therapeutic relationship, but also just for your own memory and your own learning. Whenever I give any medications, even if it's something I've given 1,000 times, I explain to the patient what it is. Okay, here's your blood pressure pill. This is to lower your blood pressure. Here's your antiarrhythmic. It does this. Here's, and so I really like this actually. I'm really uptight about never giving anything at work unless I know why I'm giving it. And I actually think I think we should all be like that. It's definitely part of our professional guidelines and what have you, but a lot of people don't. So explaining it to them is really, really helpful. The note that your phosphate binders need to be taken with meals, that has shown up on a test, I think, for me at times, and that iron supplements should be taken between meals. Make sure you know about iron supplements. They turn your poop black. Make sure you know that. Every single nurse has had that moment where you go to look at a patient's bowel movement and it's black and you freak out and you think they have an upper GI bleed, and then you look at their chart and realize they're on iron and you feel really dumb. We've all done that probably multiple times. So yeah, anyway, these are just kind of, I don't know that any of these are things you might need to know. You know what? Let's talk about why we would care about these things. Weight gain of 2 kilograms or more. This is related to fluid retention. Anybody who has problems with fluid retention, whether it's from CHF or from kidney disease, we usually will weigh them every single day, so we can see if that fluid is fluctuating. If it goes up really, really fast, that can put a lot of strain on the heart and the kidneys. And so we need to know that right away so that we can diurese the patient. Increasing BP, we know why. Shortness of breath, we know why. Edema, we've talked about. Increasing fatigue or weakness and confusion and lethargy. These are all about electrolytes and your and neuropathy, right? Anyway, I think that's it for kidney. I'm going to work on doing a video of all of the meds, and then we will be done. Okay, again, if you have any questions, send me an email.